Okay guys, what we're going to do now is we're going to run through a bit of a structured respiratory assessment with our patient here, Mr. Cooper. What we're going to do is we're going to use 4 techniques. The techniques are called inspection, palpation, percussion, and auscultation. We're going to apply those 4 techniques to airway, breathing, circulation, a neuro exam, and other. Okay? So keep in mind those 4 important techniques of inspection, palpation, percussion, and auscultation, and how we're going to approach our patient to structure the assessment in a sequence that's going to give us consistency and ensure that we're not going to miss any data. Okay? So first off, I'm going to start with inspection of Mr. Cooper's airway. So when I walk into a room, I'm going to start my inspection from the end of the bed. And I'm going to start collecting all this data right from the beginning of my interaction with the patient. When I look at an airway, basically what I'm looking here for Mr. Cooper, I'm going to say, if you can just elevate your chin for me, perfect. I'm going to look at the neck region to see if there's any kind of obvious signs of swelling or any trauma that could potentially cause an obstruction in this patient's airway. I'm also looking to see if the airway is midline, or the trachea is midline. If it's deviated to one side or the other, that might suggest the presence of a pneumothorax. So it's very important that we have that central trachea. I'm also going to be looking at the expansion of the chest to make sure that there's air going in and out to the respiratory system. That's telling me that the larynx is patent and the upper respiratory tract is delivering that gas exchange to the lower respiratory tract. I often also get the patient to open his mouth. So Mr. Cooper, can you open your mouth? Stick your tongue out for me. Open real wide. Say ah. Ah. Perfect. What I'm doing there is I'm looking as far back down the palate as I can, basically doing a Mellenpatty score that we'll talk about when we look at airway management. But some of our interventions lead down the road of intubation. I'm making a mental note of what the Mellenpatty score is for Mr. Cooper, as well as seeing if there's any kind of obstruction or foreign body that can be easily removed in the back of Mr. Cooper's mouth. The last thing I generally do is say, Mr. Cooper, can you cough for me? The cough is an important physiologic mechanism that protects our airway. So that cough mechanism being intact like that, that's a good sign. Okay? Moving down to palpation of an airway. Palpation of the airway is basically you want to feel the trachea. So Mr. Cooper, I'm just going to feel at your neck here. And I want to feel the trachea. You can feel all the different cartilaginous structures, the thyroid or cricoid and all the different tracheal rings. And it feels like it's in the midline. Okay? No deviations that would kind of identify to me that I would be worried about a pneumothorax in this instance. This is also a good time to feel for any kind of subcutaneous emphysema, any air that's tracking up through the subcutaneous spaces. Again, might possibly be a sign of an air leak or a pneumothorax. Generally it does track up, so this might be your time while it's exposed to feel for that. It feels like Rice Krispies under the skin, kind of. Okay? Now moving on to percussion of an airway. Well, we really don't percuss on an airway, so for that part of the exam that's not applicable. Skipping now down to the 4th technique of auscultation. Auscultation of an airway is sometimes obvious, sometimes it's audible. If your patient has an upper airway obstruction, there could be an audible adventitious noise called stridor. That will also usually present in some sort of respiratory distress with the patient. I have seen or been encountered with patients that have very minimal stridor, it's not as obvious as an audible stridor, so you can actually use your stethoscope and just auscultate right over lightly over the trachea. Take a couple deep breaths in and out for me. Good. And just kind of try to focus to see if you hear any of those stridorous sounds. That also might be useful when you are using your auscultation with your breath sounds to see if any of those adventitious sounds you hear in the respiratory tract are transmitted into the upper airway. Okay, so that's basically my assessment of the airway. Inspection, palpation, I don't really percuss an airway, and auscultation is one of those things that you can do if it's less than obvious and they kind of look like they have an upper airway obstruction. I'm going to move on now to B, which is breathing. So for breathing, under inspection, basically walk in the room again and you're trying to collect all this information from the patient at the end of the bed. I'm just looking for bilateral chest expansion. If I see unilateral chest expansion, that might be telling me that there's an obstruction of bronchi or pneumothorax or a big effusion, something that's creating asymmetry in his respiratory pattern. I'm going to be looking for any intercostal indrawing, so any signs of distress where the physiology or the pressures in the thorax are generating enough negative pressure to suck that skin into the intercostal space. You can look for tracheal tugging here, as well as nasal flaring. These are all signs of respiratory distress. Mr. Cooper, can you demonstrate a tripod position for me? I'll help you out a little bit here. A tripod position is a typical position that you'll see patients with COPD or any severe respiratory distress present in. And they'll have this look about them where they're trying to almost hold themselves up and use their accessory muscles like their sternocleidomastoids, their scalenes, even some of their abdominal muscles. And that's creating active inspiration as well as active expiration above and beyond that normal diaphragmatic breathing. So if you see this, this is kind of a typical sign of respiratory distress. You also, again, want to look for those accessory muscle use. So sometimes you might see some shoulder shrugging like this. Good. And that, again, is alerting you to the level of work of breathing and shortness of breath that your patient is presenting in. So when you're going to palpate for breathing, one of the techniques that's commonly used is a W sign with your hands. You take your thumbs and make a W with your hands. What you're going to do here is you're going to find the vertebral column, put your thumbs on the bilateral side, so one side or one on each side of the vertebral column, and your hands are going to kind of just cup underneath the scapula. You're going to ask your patient to take a nice deep breath in for me, and out. In, and out. I don't know if you can see that on the video, but my thumbs are actually separating with that bucket handle movement of Mr. Cooper's ribs when he takes that deep inspiration. That's showing me that he's got bilateral chest expansion. Now, if he didn't have bilateral chest expansion, you might see one side kind of be more pronounced in its movement than the other. That could suggest pleural effusions, pneumo, some other sort of finding. Now, this isn't a definitive test, though. If any of these tests kind of alert you to something more, or that we're going to require more investigation, you're going to require the physician to put in a requisition possibly for x-rays or some other sort of test. Alright guys, to percuss for breathing, there's an alleyway here that kind of is defined by the lateral border of the scapula and the medial border of the vertebral body here, the vertebral column. So right down this area is kind of one area where you can percuss. You don't want to go onto the bony area because that's going to create a very dull sound. So you want to find like those intercostal spaces. And essentially what you do is you make a little bit of pressure with two fingers. I use my index and middle finger. And with your other hand you just try to see if there's any different sounds, quality of the sound in that area. You can also get your patient to sit back and percuss the other lobes as well. Okay? Again, get into the intercostal space. Now, obviously, Mr. Cooper doesn't have any kind of findings at this point, but if you at home wanted to practice this kind of technique, you can percuss over your liver to generate one sound, and then percuss over your lung to generate another sound, and over your abdomen to generate a third sound. See if you can actually hear the quality and that difference in that percussion note, and that might lead you to, when you do pick up one of these findings in a patient that has a significant finding, it might lead you to further investigation. Again, like palpation, percussion shouldn't be seen as a definitive. This should lead you to further investigation such as the x-ray or further exams by the physician. Okay guys, when you're going to auscultate a patient, the ideal position is to have them sitting straight upright, dangling their legs over a side of a bed. If they can't do this for whatever reasons, if there is any kind of discomfort or maybe T or L or C spine precaution, you're going to have to work around this assessment. So by knowing the anatomy of the thoracic cage and where the lungs are under it, it's very, very important that you can locate the different lobes of the lung. Okay? So here we've actually drawn on or superimposed the lobes of the lung on the posterior section here. So you can see left upper, left lower, right right upper, right lower with the fissures in between. What you want to do when you auscultate, you can go from apices or bases. You can start wherever you want. I generally start at the apices first. And what I do is I kind of make a J around the scapula, okay, and a backwards J around this scapula. You don't want to really listen over that bony structure just because you're going to get some altered findings. So what you want to do is place the diaphragm of your stethoscope right on the landmark that you've identified, and ask your patient to take a deep breath in and out through their mouth, and you want to listen for one entire respiratory cycle. Deep breath in and out. Good. And now I'm going to compare that right to the other side. Deep breath in and out. Good. I'm going to move down. Deep breath in. Out. Good. Again. Good. I'm just going to keep moving down, working the anatomy. If you hear an adventitious sound, stay there for a second longer, a couple more breaths, and really try to quantify and qualify inspiration, expiration, late inspiration, late expiration, early expiration, and what it is you're hearing. Okay. Now, as we know on the posterior chest, you're going to get a lot of the lower lobes. So to get the middle lobes, you're really going to have to go off to the side. On the right side, you've got the nice defined middle lobe. On the left side, you've got the lingula, so you can still auscultate. If you get your patient to turn to the side, so if Mr. Cooper, if I can get you to sit back there for me. Lift your arm up. So on the left side, you can see this major fissure kind of separating the left lower and the left upper lobe. I still try to auscultate along that fissure line just to get up that lingula and see if there was any kind of fluid collecting on the lingula. I'll get you to dangle your legs on this side of the bed here, Mr. Cooper. And on the anterior chest, you can see the upper lobes, the middle lobe on the right, and the lower lobe is way down here on the mid-axillary line. On anterior auscultation, you're not going to get a lot of the lower lobes. That's why it's really important to do a posterior auscultation if you can as well. The way I approach this auscultation is very similar. Take a deep breath in. Out. Out. Try to get the left lingula. And then that lower lobe. Good. Now you obviously can position your patient so it's comfortable for both you and them to get the findings objectively, and really focus on what you're hearing so that you can communicate that data to the team. Alright guys, we're going to continue on with our assessment. We're going to start looking at inspection of circulation. So generally, respiratory therapist's best friend is a pulse oximeter. We don't go anywhere without this thing. I put this on right at the beginning of my assessment and keep it on for the entire duration. It not only tells me a pulse rate and a saturation of oxygen, but it also tells me something about the circulatory system. Now, if Mr. Cooper's circulation is intact peripherally, his radial and ulnar arteries are supplying the tissue in his hands with oxygenated blood, and that'll pick up through the wavelength through this oximeter. So that's telling me that his blood pressure is at least adequate enough to supply the tissue in that periphery, and he's not shut down, he's not shunting blood to his core. So in a non-invasive way, this is actually telling me quite a bit. I don't necessarily have to palpate and count for a pulse rate. It's a good idea just to check if the number on this device, so right now Mr. Cooper's pulse rate is 66 beats per minute. It's a good idea just to check at a radial or ulnar or carotid or femoral. We're going to get that when we do palpation, but just to double check the findings on your pulse oximeter. But as far as inspection goes, For circulation, I guess the first thing you want to look for is to see if there's a JVP. So essentially, you find that angle of Louis, 4 finger breadths up, see if you can see any kind of distension of that jugular vein. Ask your patient to turn their head, so turn your head to the right there and you can evaluate it. Turn your head to the left, evaluate the other jugular. Another thing you can do in inspection of circulation is look for any kind of dependent edema. If there is any kind of venous insufficiency or even arterial insufficiency, you might see fluid collecting in some of those dependent areas. If they've been in bed for a long time, this may not be the dependent area. It may be posterior. If they're standing upright, then generally a lot of the fluid will collect in the ankles and in the lower extremities. Okay guys, one of the other things that you can do while you're down in the lower extremity looking at that dependent edema is you can check for pitting edema, so to see how long that fluid's been there. Basically just by pressing on that lower extremity and seeing if there's any kind of indentation left by the pressure that you've put by your fingers. Another thing you look for in your inspection of circulatory system is the peripheral cyanosis, so looking at nail beds, seeing if there's any kind of bluish tinge on the nail bed that might suggest insufficient arterial oxygenation supply to the tissue. This also might be a good time to look to see if there's any clubbing of the fingers that might demonstrate a chronic hypoxic state in that tissue bed. And now we're going to move on to palpation of the circulatory system. So there's a number of pulses that we can palpate that I've already made mention to. Most frequent and most accessible for us is that radial pulse on the thumb side here. You got a radial pulse. On the pinky side, on the pinky finger, you've got your ulnar pulse. So those are your peripheral pulses. You want to be able to adequately judge the quality and quantity of that pulse. So frequency, you can verify that with your pulse oximeter, as well as look for the strength of that pulse. Is it regular? Is it bounding? Is it thready? Is it weak? A lot of the different information that you can get from palpating those pulses. There's also a brachial pulse here, and if we were going to do a blood pressure, you'd find the brachial pulse. Carotid pulse for central pulses if they're peripherally shut down, and femoral pulse is another great central pulse. In the event of a cardiac arrest, never go for peripheral pulses because blood will always shunt to the vital organs. In any of those type of hypoperfusion events, always go for central pulses. Okay? Number of different ways to actually do a blood pressure. In clinic, most often we've got non-invasive blood pressure or automated blood pressures, which is you basically put the cuff onto your patient's arm. Usually there's a size range. It'll even tell you where to find the artery, so palpate for the brachial artery. Line up your marker and ensure that your cuff is a proper fit. Now there's two ways to do a blood pressure. The first way is by palpation. So you can feel the radial pulse, and you can inflate the cuff just until that radial pulse disappears. And by slowly turning the valve on the bulb here and letting some of the air out of the cuff, palpate for when that pulse reappears. So as soon as I feel that pulse come back, that's my systolic pressure. So Mr. Cooper's systolic pressure here is about 115. I can't get a diastolic reading from a palpation and blood pressure technique. The other way to do this is by auscultation. So palpate for that brachial artery. Put your stethoscope on. Put the diaphragm of the stethoscope right over the brachial artery and inflate your cuff watching your manometer. I generally pump it up about 2 or 3 more squeezes above where I stop hearing the sound of the artery or the brachial artery, and slowly deflate the cuff until you hear what's called a crock cough sound. As soon as that sound comes, you'll start seeing the needle bounce after that. That's your systolic. When that sound and the needle stop bouncing, you've got your diastolic pressure as well. Mr. Cooper's blood pressure is about 115 on 78. Alright guys, kind of coming to the end of our assessment here. We're going to now move on towards a very, very minimal neuro exam. Physicians will do a whole mini mental examination where they evaluate a lot of the different cranial nerve functions. As far as I'm concerned, what I'm most aware or most concerned is the patient awake? Are they alert? And are they appropriate? That's going to tell me a little bit about their level of consciousness. And we use what's called the Glasgow Coma Scale, which is included in this module, to evaluate that level of consciousness. So you can also look at pupil reactivity, signs of any kind of intracranial pressure or narcotic overdose, etc. But as far as I'm concerned, I really just want to get an understanding of how awake and alert and appropriate that patient is. So oftentimes I just ask simple questions. Hi, Mr. Cooper. Are you Mr. Cooper?
Yes.
Mr. Cooper. Do you know what day it is today?
It's Friday, August 21st.
21st. Okay. Do you know where you are?
In London at a hospital.
Okay. What's your birthday?
May 15th, 1983.
Perfect. Okay, so just by some of those simple questions, I can get an idea if they're disoriented or maybe they're just confused. Sometimes they've just been in a hospital for quite some time and lose track of dates, but long-term, short-term memories there. You can ask a little bit in the interviewing part of how well, you can sort of gather how well they are of a historian in their interview and make a judgment on how neuro-intact they are. Okay, so the last thing we're going to assess in our respiratory assessment, just to make it comprehensive, is this broad term called other. We're still going to apply the techniques of inspection, palpation, percussion, auscultation. Under inspection, you're going to look at things like surgical sites. A lot of pain and discomfort can come from surgical sites, and that can emulate into respiratory distress. Urine output is a really big factor for us to pay attention, and overall fluid status. Overall comfort, basically, even if it wasn't derived from surgical site, pain can be a big issue and often manifests in respiratory distress. This is a great time for us to step away from the patient now and look at our labs, so white blood cells, your hemoglobin counts, your electrolytes, arterial blood gases, what have you, and as well to evaluate your chest x-ray. Okay? I know as respiratory therapists we don't necessarily do a lot with abdominal contents or assessment, but looking at the distension of the abdomen can play a big factor in respiratory distress. If that abdomen is quite large, it's going to impede the chest expansion, basically press up on the diaphragm and prevent the lungs from completely filling. You can also palpate that abdomen. I've done this a number of times where you just basically feel how hard that abdomen is. Is it soft? Is it tender? Or is it rock hard and distended to the fact that you're going to start to be concerned that it's going to compromise that respiratory system? As well as for percussion. I don't pretend to be an expert on percussing abdomens, but there are techniques that you can use for that. Under auscultation, I can't really think of any types of auscultation techniques that we'd use in this other format, but this, I'm sure I'm missing some. This is a very broad spectrum, and this will essentially create that all-encompassing, comprehensive assessment for our patients.